So our next presentation, Dr. Chang is going to keep on rolling with us. And then we have Dr. Christine Sindt joining us as well. And they are going to discuss what would you do? How to select an appropriate contact lens option for your keratoconus patient. So Dr. Chang, we just did an introduction with him earlier. So we'll go ahead and introduce Dr. Christine Sindt. She is a graduate of the Ohio State University College of Optometry. Got to pronounce that B in there. She completed a disease-based residency at the Cleveland Veterans Administration Medical Center. She joined the faculty of University of Iowa Department of Ophthalmology and Vision Sciences, where she is currently the Director of Contact Lens Service and Professor of Clinical Ophthalmology. She also serves as a consultant optometrist for the Iowa City Department of Veteran Affairs Medical Center, holds 7 U.S. patents, and has over 150 publications. She regularly travels to conferences both nationally and internationally. And we're so excited to hear from these two experts today. So thank you guys for joining us.
Thank you, Dr. Sorenzi. I figure it was much more worth the time to introduce Dr. Sindt than myself. So hope everybody is okay with me fast forwarding through my bio.
You need no introduction, right?
Thank you. Okay, so I know we got lots to talk about, and we, as in our usual fashion, always try to pack in like more than 1 hour of C content into 1 hour. So let's get this started. So I want to talk about, obviously, with the rise of scleral lenses, and it's very exciting, but I think Dr. Sindt and I want to, thought this would be a good reminder for us to say, don't feel like you are being left in the dust or for your patients if your first recommendation is not a scleral lens. There's still times where other lenses can actually be quite appropriate and sometimes even higher rate of success. So my fellow at the time, Dr. Angela Sheen, and myself and Dr. Peter Hirsch, we did a retrospective review of 329 eyes, all patients fit by me. And majority of them after cross-linking, after intact. So there's some sort of surgical means that are being provided or intervention. And so regardless of which lens I first start with, the rate is 76% success rate. And then if I could quickly figure out what the reason is that first lens design didn't work, maybe it was just the patient has tremor and unable to handle a larger lens. Maybe that's the reason why we go back to a corneal GP or something like that. You could see the difference a success rate that rises really quickly to very close to 100% pending how many lens designs you have available in your office. And also there's possibly, I think that, the perfect coupling type of concept where, remember I mentioned the fact that a lot of these patients in the 329 eyes that were retrospectively reviewed, a lot of them had actually had surgical procedure or medical treatment procedure done, and look at the difference, although the end outcome seems pretty similar, meaning that tolerance level, but you could certainly see the discrepancy is much higher when we combined it with a surgical treatment versus, patients who we determined that they probably don't require surgery or medical treatment. But that points out the fact that potentially surgery combined with contact lens design properly fit to a patient can actually provide even more improvement to the quality of life to our patients. And so let's demonstrate these points with cases. So this is a case of my patient, 68-year-old white male with a long-standing history of keratoconus, never really all that happy with glasses or any prior contact lenses, especially noting that gas permeable lens was not as comfortable and most importantly, didn't feel like any contact lenses that he had been provided in the past was any better than glasses, which sounds really weird, right? Because if you look at that right eye with that staging of keratoconus, makes sense on the left. So potentially there are a couple things, right? Either this patient is one of those patients who have tuned out right eye completely or so much with some amount of possibly suppression that this patient's only focusing on through the left eye, and therefore contact lens didn't appear to be that effective, and that's where sometimes that keratoconus asymmetry can actually be tricky in fitting our patients. Or possibly there's something else going on with the contact lens design that can be refined better. So we start with our clinical examination. Patient came with limited records that we could review. As far as we can tell, we feel like this patient likely is stable. Not that it's impossible for patients in their 60s and 70s to continue to progress. But we feel like with the limited chart review and looking at refractive records as well from the past, that this patient likely is stable. But look at the amount of anisometropia this patient will have to deal with. So again, makes me think that possibly really more viewing your visual cortex for this patient is really paying attention to the left eye, not the right eye. And that may be the reason why. Regardless, we recommended the patient to actually return to his primary care optometrist who made the referral and say, why don't you just try a different contact lens and see if there's something else that could make you, appreciate your vision better. But the patient was very adamant about, no, I've tried it for 40 years. I really need you to do something before I go back. I'm willing to go back and try contact lenses again. I just want to see if there be some improvement, at the very least, in my glasses or on corrective vision before I go back and try contact lenses. And we say, okay, that's fair. And let's try Intex and see if we could reshape your cornea so that it may improve your either uncorrected or spectacle vision, even by a little bit, which you had heard from Dr. Greenstein earlier today. So we did that, and you can see the anisometropia decreases, still obviously there, but within maybe acceptable limit for even regular cornea patients, and much less astigmatism on that right eye. So patient came back another 6 months later after that and say, well, the contact lens is comfortable. My hybrid lenses are really comfortable. I can wear them all day. And this is the lens that he came in wearing. In both eyes, actually very similar pattern. So I typically if you look at this hybrid lens, I typically under the central GP, prefer about 100 to 120, maybe plus minus 30 in terms of that central clearance. I like to see the junction to not be bound to epithelial surface. So I like to see fluorescein kind of bleeding out, if you would, underneath the junction. And usually that means the lens would actually have pretty good movement. So you don't have that sort of tight lens syndrome at the end of the day. So I think that lens is fit really well. And the patient says, again, it's the same thing. It's comfortable. I wear them all day long now, but I find myself going back to glasses because it's still, if anything, I think the vision, this is the patient, I think the vision is actually worse than my glasses in hybrid lenses. And then now that's really odd again, why would that be? Well, maybe possibly if you look at the contact lens vision, few letters less than in the left eye that I think he's probably paying much more attention through. So I thought, well, I don't know why that is. You would think that with the corneal GP that should be largely taken care of either in both left and right, or at least in the left eye. So I did a spherical cylindrical refraction and got him to, in the left eye, got him to 20/20. If I just put that little bit of plus 75 minus 1 cylinder in front of him, and with trial lens and viewing in both eyes, he really enjoyed the vision. And so I thought, okay, well, that means that you have two choices. Maybe just continue to wear your hybrid lenses. We could, since you're like your glasses quite a bit, you probably don't, and you need your progressives anyway, maybe just wear that over refraction in your glasses and I'll prescribe you progressive. I can do that, but I really prefer to see if I could, for my distance vision, I'm outdoor all the time. I don't mind putting on reading glasses. There's something else you could do. So we talked about possibly front toric scleral, or maybe trying, again, given the fact that his left eye seems rather mild in keratoconus, that maybe a custom soft keratoconus lens like a Novacone could work, and especially if we try to get the left eye better than his glasses. So did the fitting with the recommended base curve from the manufacturer. And this is what the lenses look like. You could see the index on the eye. So I typically like to still use large molecular fluorescein. I realize you could fit these soft lenses without, but a lot of times that kind of gives me a sense of how close, because it's still, it's a thicker lens than that allows the accumulation of the tear lens, but that thickness and the weight of the lens can still be rubbing against the corneal apex. So if possible, I would prefer to avoid that as much as possible and have a little bit of filler clearance at the apex. So that's where that's where the optic section can be very important, kind of just looking through the lens to determine the amount of fluorescein. So the patient saw really well, came back really happy, but noted that when he removes his lenses at the end of the day, because again, he's wearing them, all day long, that he has his glasses is now not as good. So, spectacle blur. And if I compare the topography of prior to soft lens, prior to custom soft lens fitting, right after the intacs in the middle, and then when he came back wearing during that visit, after 4 to 6 hours of wearing the Novacone lens, I can see that there's an area relatively close to the central area that where my arrow is pointing that has some amount of flattening. So I went ahead and I changed the base curve from A6 to A2. And then I noticed that there's just a tiny bit in the left eye, not the same way as the right, which is probably, I'm assuming he's not noticing as much, and he confirmed that. So I really just changed, since I was reordering lenses anyway, changed the base curve ever so slightly, probably unnecessary. And gave the patient over refraction. His vision was even better than I first predicted. And again, he's really happy. And came back and no more spectacle blur after I changed the base curve of the soft lens. So it shows you the importance of having that little bit of persistent tear lens underneath that soft lens all day long, or at least for most part of the day. And you could see the difference in the higher order aberration even through a soft lens for this keratoconus patient. And so I just obviously I understand that soft lens may not be the first tool that we would use, especially in patients with enough amount of higher order aberration. Some sort of gas permeable lens, whether scleral corneal, probably would still be, it is likely still our standard. But I do want to quickly mention before we get into the next case that it also depends on that corneal height and exact location of the apex in terms of how to determine what size of corneal GP, right? Because if it's a central cone, I think everybody agrees that's super easy. You could do small, you could do medium, you could do large, because it's pretty symmetrical in the peripheral area for you to balance your corneal GP regardless of what diameter, right? But the more peripherally located the cone is, the more asymmetry top and bottom, it's very difficult to do a bitoric on a keratoconus patient and have it very stable. It's not impossible, just much more difficult. So therefore, even though the general rule is get bigger and bigger to find a zone of pretty even landing so that the lens will be somewhat stable and likely always slightly inferior decenter in that situation. But there's a time such as what you're seeing here where the cone is so large and it's relatively inferior, it's always going to have you're always going to run into a problem of asymmetry between using a large diameter. In a case like this, it's a very severe, or even just frankly an early pellucid. I actually recommend we try to shrink the diameter of the lens to try to find an area within centrally that may be more even to balance the lens. So I think that would be one exception that I would say, don't always go to the largest corneal GP. And I think Dr. Sindt's case will demonstrate that.
Thanks, Clark. Yeah, I've packed a lot of little nuggets and pearls into this one case here. So a lot of things are going to come out here. So I'm hoping everybody's got their listening ears on, because we're going to go through this pretty quickly, unfortunately. So I'd like to present a case of a 50-year-old woman who came to me. She'd been piggybacked in the past. She was wearing scleral lenses. They were 3 years old. I had not seen her before, but she had reported that she thought her sclerals were more comfortable, but she really felt like she couldn't see out of them, and felt that she had better vision in her gas perm lenses and in her old piggyback system. And she really did not want to consider surgical options at this time. She really wanted to stay in her contact lenses. And so she came to me wondering if she could go back into GP lenses. I know this sounds a little unusual, based on everybody's trying to push people into scleral lenses, but she really wanted to go back to her GPs. And so if we could go back one slide here, Clark, just to point out a few things here. One, with the picture, you want to see here that her apex of her cone really is quite center there to that inferior pupil margin. But when I look at and evaluate a patient, I don't just look at their sagittal curve, their K values, if you will. I also look at the elevation map to see where that cone is located. And so, as you mentioned, Clark, wow, this is a really centrally located cone. So when she said she wanted to go back to GP lenses, I was like, woo, woo, yeah, I can do that. Heck, like this should be a pretty easy slam dunk. Now, one of the things I do want to point out with the curvature map, though, is if you notice the difference, her central Ks there are, in the 70s, mid to low 70s, whereas her periphery is really quite flat in the low 40s there. So that means we have a really significant change from the center to the periphery of the eye. And so we do want to consider that a couple of things. One, the larger the lens you go, the more you have to take into account that curvature change over the entire cornea so that you don't end up bearing. The other is how high that cone really is to be changing there. So you've really got quite a depth and a width that you have to consider when you're fitting this eye. Now let's go to the next slide. Okay, so the first lens that I put on her, I'm thinking, well, she's been used to a very large optical zone. Maybe I want to keep her in a larger optical zone. And so we put on an X-cone lens. Now, an X-cone lens is a reverse geometry lens. The advantages to fitting a reverse geometry lens is that you can go larger and that you can actually alter the vault of that lens independently of the base curve, meaning that you can have a flatter base curve, but you can use that secondary curve or that mid periphery to give you a little more vault, much like you do in a scleral contact lens. What you're going to notice, this was the steepest lens, or the most vault, I should say, that I had in my fitting set. And what I do want to point out here is we really had a lot of central bearing, way too much central bearing in this case. Now, a reverse geometry lens fits differently than the next type of lens that I'm going to show you on this patient. And I think of fitting, no, go back. Yep, thanks. I think of fitting these patients like trying to put a hat on somebody's head. So if the cone is your hat and your shoulders are the periphery, what type of hat are you going to choose to fit on that lens? Now, and reverse geometry is much like fitting a top hat, right? And you can use that mid periphery. Do you see how we have bearing almost 360 degrees around? That's sort of like the band on your top hat. And that is the area that you use to adjust the fit on that contact lens. So the more vaults you have, right? And this is the common saying, steep lens ride low, flat lens ride high. So even in this particular case, the lens looks very flat. It actually has quite a bit of vault. So really it should be high vaults fit low, low vaults fit high, right? So if you want to get a lid attachment, you're going to have a lower vault or have that ride up high so you can get that lid attachment. What I want you to see in this particular case is we choose a large lens because we want more pupil coverage, right? We choose a large lens because we want to force centration on the eye. But what happens in this case is that lens is dropping because it has a lot of vault. That lens is dropping and it's hitting that lower lid. And so every time that lens hits that lower lid, she feels it. This is uncomfortable to her. So in this case, her discomfort is not from the lens itself. It's not from blinking over the lens. It's from that lens hitting and riding on that lower lid. So in this case, we're going to have to go to a smaller lens to try to get away from that lower lid. Now you can go to the next slide. All right, so we went with an 8.3. Now, if you have a very steep cone and you want to fit a standard lens, this is like fitting a sombrero on the head, right? You're fitting over that cone and then gliding out into the periphery. And so when you want to fit a very steep cone, I want you to really think small lens. If you've got that small, steep central cone, think small lens. And an 8.3 is a great place to start. But you'll see, it's difficult to see in this photo, but she has, because there's a lot of anterior fluorescein on this eye, but she has a lot of central touch there in that eye. So she's got a lot of central bearing. So clearly in this case, I need to go to a steeper lens. We've got too much. Now with this type of lens, you have that typical 3-point touch, right? central 3 and 9 o'clock touch. You don't have that band of touch like you would be looking for in the periphery of a reverse geometry lens. Okay, so we went with a steeper lens. But this time the lens dropped, right? So I always go up by, I don't go up in 0.1 increments, right? I always try to go up in 0.2 increments because you can always come back once you overhit it. But in this case, we went up by the 0.2 increments. And now the lens picks up and just chunks back down to that lower cone. Steep lenses ride low, more vault rides lower, right? So you want, in this particular case, she's starting to feel it again because she feels it on that lower lid. So I need to go back. I went up 2, I need to go back 1. So if we go to the next slide. Okay, so we picked that 1 in between, that 0.2. And you'll see now we have this nice lid attached fit, and it graces over that cone, and there's no lower lid interaction. And she sees well and she feels good. So this is the ultimate place that we want to end up. She has good edge lift on this lens too. So the lens is moving well. Okay. So when you think about these advanced cones, this nice central cone, in her particular case, piggybacking had not helped her because her problem was her eyelids, not the cornea itself. So if you piggyback somebody and they still feel they are still uncomfortable, I want you to think, what do I have going on with the eyelids in this case? And am I touching or hitting the eyelids? Is the lens moving too much? And you may want to consider altering your design to alter that lid interaction. In a reverse geometry lens, like we tried first, it allows for a flatter base curve, but since her cone was located centrally in this case, we also had the option of going to a smaller design, which was her better option in this case to keep her away from those lids. A scleral lens is often a very good option for these steep central cones as well, but when you get too steep, when you get too advanced, and then you vault the cone altogether and you don't have that gracing touch, sometimes you tank their vision. And if their goal is to stay out of surgery for as long as possible, sometimes your best option is actually to touch the cone and keep them out of surgery longer, knowing that they're eventually they may need surgery as well, and educating that patient accordingly.
And I do want to point out, sometimes I completely agree with you, of course, Dr. Sindt. That's not surprising. But yes, piggybacking is not going to help the patient with the lid discomfort and the interaction of the edge hitting the lid margin. Sometimes, though, depending on how you alter the GP fit, if you do a piggybacking, provided a soft lens can stay on the eye, it will reposition the GP lens as well. And so that is a possibility. But my question for you is, how often do you take the patient's word at face value during chair time, meaning they feel the lower eyelid? Or do you sometimes say, well, I've tried to move the lens up a little bit, you're still feeling the same area. Maybe let's get the lens ordered. Let's have you try a few weeks, then come back. Like, what do you think of, do you ever give some adaptation time, or do you take their word?
No, there is always adaptation time for our patients. So I think that if you have a lens for the patient and they can see out of it, just having them try the lens for a while, there's really not much to lose to have the patients try to adapt to a lens situation. A lot of it comes down to listening to the words that the patient's saying, though. And I think maybe that's where some of my experience comes in. I see how the patient is interacting. I watch their body posture. And I know my own personal abilities and where my experience has led to me. So sometimes I may jump a little bit faster just based on the experiences that I have had. I don't think we ever lose time so much having the patient try things out for a while. But I listen to the patients, and I think over time that's my best tool is not just hearing the words, but how they say it and how they feel it as well.
Yeah, absolutely, completely agree. So why did we talk about let's not go backwards here. Why did we talk about the bearing, watching out for the sodium fluorescein pattern? In this case may actually not lead to where you think this is going. So corneal GP, right? We know that from CLEC study that 31% of patients associated with flat fitting corneal GP at baseline, 31% of them were observed at the end of a year study to have scar versus only about 9% with steeper fitting lens corneal GP at the outset, at the baseline of the study. So possibly then that association is something we shouldn't ignore. So here's a patient who actually came in and say, I already know that I have corneal scarring. I was told that, it occurred 3-4 years after I started wearing corneal GP, but I was wearing too long, but I needed them to see. I had no other choice. And progressively, my vision has gotten worse. And now I'm being told maybe corneal transplant because of my history of corneal scarring. You're my last try. Is there anything that you could do before I go get a corneal transplant in both eyes, because it's similar in both? So we can see that in the incoming lens that patient is wearing for the first visit. Yeah, I see there's corneal central bearing that I normally would hope to avoid if I could. And there's that white opacity on the cornea that sort of corresponded with his intake of saying, I already know that I have corneal scarring, except when I looked at the slit lamp without the lens more closely. And I thought, that's interesting, because we already talked about in different lectures that non-inflammatory, right? Clinically non-inflammatory findings for keratoconus patient. But yet you could see, number one, that coloration make me feel really odd that that's a scar right there. It's not as fibrous, if you would, or fibroblastic type of change that I usually think a corneal scar looks like. And it looks rather creamy in the center to me. So I purposely looked at that area under a higher magnification and saw these very active neovascularization. So I didn't think it was a corneal scar. I thought it was more lipokeratopathy, probably due to the compression of the corneal GP. And the good news to him is, number one, with those neovascularization, even if he's going to end up with corneal transplant, I would prefer to see if there's something that I could do to get those vessels to reverse course a little bit or dry up a little bit. And I really thought it was probably that it looks more lipid-like to me rather than the fibroblast type of scarring. So I thought, well, what if I would put him in a piggyback first? He just recently purchased a new set of lenses. He didn't want like a whole, purchase new lenses. We talked about scleral to maybe be able to maximally relieve that compression pressure. So I said, why don't we try piggybacking just for like a few months? There's 3-6 months, and let me see you back. And by then, it's a year something into purchasing the first set. Either you have some improvement or you don't. If you don't have improvement, then let's do a evaluation for corneal transplant. If you have improvement, then maybe we could progress towards having scleral lenses. So this is what happened a year later. And he actually progressively got them better from piggybacking. And the vessels, I couldn't find them anymore, so I didn't photograph for you. And his vision went from 20/50 to 20/25. Eventually in a scleral, went another year into it with the fluid protection and the ecosystem underneath the lens improved his cornea. He actually was so clear I couldn't photograph anything for you. So that's why I don't have the next set of photos. And he did reach 20/20 minus, which was pretty amazing for him. And it's just, it spared him from having to undergo transplant, or at least greatly defer the need for that. So, always make sure that we cross-check our findings with the definition of the disease in order to guide us in selecting lenses for patients.
It was interesting, Clark, when we were prepping this lecture earlier, and we went by these photos really quickly, and I went, whoa, back up.
You did.
I said, talk to me about those muscles, right? One of the things that I just looking at, since it's a fitting lecture, one of the things, if you look at the fitting photo up top, that just strikes me right out is how tight that periphery is, right? And just how that is really clamped down there, and how low that lens is riding. And so 2 things just regarding those blood vessels there inferiorly that come to mind that I just want our viewers to think about is, one, do we have an area of maybe some limbal stem cell irritation or deficiency going on in that area because of that very tight low riding fit, which if I can imagine it, I'm just imagining it there. If I were to pull down that lower lid, that lower lens would be just riding right on that inferior limbus. But the other thing that comes to mind, and this is always 100% in my differential diagnosis, is are those deep ropey vessels there, herpetic related, right? So herpetic related vessels with lipid keratopathy should always be in our differential. And why? Because in our notes, you should clearly document this, like Dr. Chang has documented it there, because this can bite you in the butt later on. I mean, that if it's herpetic, you can do a scleral lens fit, and then later on have these vessels come back for no apparent reason and quite aggressively and quite quickly. So it's something that we should always just keep into our differential.
Yes. And so going into our next case then, this is actually a case that had always stayed with me because it's one of those cases where I thought, even I wish we would have acted a little bit sooner. So this patient, left, right eye, pretty similar, came with the, my prescription. Every 6-9 months, they just keep changing my contact lens prescription and always tells me that I see 20/20 and there was nothing that they could do anymore. I see a lot of halo glare start bursting. I find it really difficult to drive. Young, I think he was graduating and about to go to college. I don't know what to do. I don't really want to go to school because I'm very uncomfortable. And we thought, maybe you just have, and he did have very large baseline scotopic pupil. And so we thought, well, it could just be that you're seeing the spherical aberration at night from your the marginal rays. And maybe that's what it is, because we did wavefront aberrometry. Really nothing was like we're looking for elevation in, vertical coma, spherical aberration, even, to be honest, wasn't all that. So it wasn't all that elevated. Cornea looks clear, but we already talked about the fact that anatomical signs are not going to come early. There's no inferior steepening looking at the axial map, of course. And then the pachymetry isn't all that thin if we're only going by one point of pachymetry. There is some elevation that we thought, well, he just took off his soft lenses. Could it be dryness? Maybe it's something else. And he was corrected both in spectacle, manifest refraction gets him to 20/20 in both eyes. So we thought, maybe that's watch. Let's see if we could just have you get, refit in a different contact lenses. He said, okay, well, fine. That's just make sure that he agreed to close monitoring. And 6 months later, even though there's still no inferior steepening, you could definitely see the posterior elevation, anterior elevation, all increased. And you're starting to get that sort of crab claw, pseudo-pellucid type of pattern, even though there's still no inferior steepening. So you really can't just say, IS ratio asymmetry like we talked about in the last lecture. So I did wish that I would have been able to help this patient a little bit earlier rather than putting him through contact lens fitting for like another 6-7 months in between these two exams. Eventually was included in the clinical trial for our own individual IIT at that time, because this was pre-FDA approval for cross-linking. However, when he stabilized, a month afterwards, we started talking about, okay, you've been wearing your, soft lenses that I had prescribed you when I first saw you. What should we do now? Epithelium healed very nicely. Still getting the, halo glare. Why don't we, and this is the part where I don't know why I didn't listen to myself. I already noted that his pupil was rather large. I suggested because I thought he would like something that looks like a soft lens with a corneal GP optic. So, and it has done really well for a lot of my keratoconus patients. So I said, why don't we try hybrid lenses? Because, your corneal topography we should be able to fit you in get a fit in the hybrid lenses quickly. And the reason I said, normally it's a really good lens that I even went with the largest OZ that I can get in the modern hybrid lenses using the A design rather than the clear cone or the ultra health to just get the slightly larger OZ, thinking centration of the lens is going to help. He actually came back and said, nope, it didn't really help. In terms of vision is good, yes, but that halo glare I still see all day long, and especially at night. Using brimonidine does help at night to reduce his pupil. And I do want to say that the soft screws, sometimes if you have mild elevation, something like a pterygian or pinguicular hybrid lenses in a keratoconus patient actually works really well without having to design, a vaulting area underneath to be gentle over that scleral barrier or obstacle. Regardless, we went to a larger diameter GP to be able to get a larger OZ, very similar to the last patient that Christine had talked about, and so that I could get larger OZ. And you could see, clearance and centrally over the cornea. Is it better than hybrid lens? Yes, to the patient. There's less halo glare, but still sees it, especially at night, and he still finds it very non-functioning, no matter how I tried to go slightly steeper with the lens to make sure that it doesn't move as much as a normal GP, but still have tear exchange. And thinking a larger OZ would always be inclusive to his visual axis, despite the larger pupil. And so eventually I have to put him in, and you can see with the same GP, this one is more centrally located with a piggybacking with a prosthetic, that same lens right up, right? Because now it's fitting over the elevation profile, combining with the lens, not just the cornea. So either way, got him into, and I would recommend if you're doing piggyback to, regardless of whether it's prosthetic, combined or not, to always do sodium fluorescein over the both lenses to just make sure, and also after you remove the lenses, to make sure if you do have touch, that you're not seeing epithelial compromises in that area of the touch. Otherwise, you should alter your corneal GP base curve. You can see the difference in the higher order aberration before and after the prosthetic piggybacking. So we'll move on to Dr. Chris Sindt's next case.
Thank you. I think that whole concept you had there, Clark, that was a great case. The smaller pupil, though, and that really affected those aberrations. And I'm going to go through this case really quickly because I want to make sure we have time to talk about those aberrations at the end of our lecture here. But I'm going to introduce my patient here, who actually came to me through neuro-ophthalmology, as all good keratoconic patients do, because he actually had decreased vision. And they thought because he had neurofibromatosa that maybe he had a lesion, and then neurologist said, well, maybe it's dry eye. So he came to me for dry eye and for a contact lens fitting for dry eye, and he actually ended up with keratoconus. So let's go to the next slide here. Now, this is a case where I just want to point out a couple of interesting fitting things for him. And really, we're going to look at his left eye here. His right eye is a pretty standard cone, central, a little bit of a haze there, but his left eye has this really interesting pupil shape. And if you notice, his cornea is not really round either. He's got this area of elevation right up there at the superior pannus area of his superior corneal scleral junction. So next slide. Okay. So when we look at this particular patient, we're going to notice that on aberration wise, he's pretty typical with that keratoconus appearance of that sort of yin yang sign that you see with coma. And one of the things I like about this particular picture, and if you could just point out the retro illumination slide image here, is that this is very similar to retinoscopy. And so I recommend to people that you that you do retinoscopy in the complete dark, get their pupil as big as you can, and then just come in there really quickly with your retinoscope real fast and know where is that cone. The pupil will shrink down as soon as you put the retinoscope there, but real fast, get in there and see where it is. And you'll see in this retro illumination image here that the cone is actually just at that inferior pupil, right there. But he's actually got some clear cornea on the top there. And that's where you want to do your retinoscopy. If you're going to try to get somebody into glasses, you want to see if you've got enough of an area of clear cornea, because you'll notice with people with keratoconus, their prescription can be -16 or -2 + 2 axis something or other. I mean, they could have these and see the same between it. So if you're going to look for glasses, you're going to look for a soft contact lens, use that retro illumination to say, where do I need to target? Do a targeted refraction on these patients. Retinoscopy should not be a dead skill for that particular reason. And then, of course, going down to the tomography images, which Clark and Bill went through in quite some extent on the lecture before this. So. Okay, so we'll see again with this. I use as I mentioned before, I use the sagittal images, but I actually look at that back, the front and back floats to say, where is the actual cone? Now, in this particular case, this was a very small cone, a very mild cone. And I really could have picked, again, central cone, woot, woot, right? I could have done a corneal GP on it. Certainly there would be economic benefits to that. This particular patient worked outside, worked in a dusty environment. And when I went through the options, actually wanted to go with a scleral lens. And next. So we decided to do the CSP option where we did the corneal scleral profiling. What's interesting is that superior area there where there were some elevation differences. You really can see those differences. It's in the pink area here on that upper left-hand corner of the sky there. You can see that's really where he had started having some of those shaped changes out onto the sclera. Next slide. Okay, so go ahead, just next one. Okay. And again, when we look at that area here, at that superior sclera, that next one, yeah, you can see that and on the elevation map that is created in the ScanFit software, you can see where that's a superior sclera there. You can see that really interesting scleral shape. And really, you have to have the scleral shape match the scleral lens to not have an overvault or an undervault situation. Go ahead, next slide. And so when you do a scleral lens, when you want to fit a scleral lens, you want to make sure that you have not only good central clearance, but you want to make sure you have mid-peripheral clearance as well. You want to make sure you have the appropriate amount of limbal clearance. And then you want to make sure that if you have any bumps or any irregularity changes out into the sclera itself, that you have the ability to go over those bumps and not cause an indentation or a harsh bearing or drawing too many bubbles in from under the lens for that matter as well. Okay, next. You want to be able to move your scleral lens optics around. So part of the problem that we see sometimes is these lenses sink back, right? So they're going to have this settling factor. And then when you have a low cone, sometimes you will touch the back of the scleral lens. And it's hard to get a situation where that does not happen, and you have to start playing with those peripheral curves. So being able to move the optics around and actually decenter the optics, you can get not just raising or lowering the vault on the lens, you can actually end up with more appropriate clearance across that whole keratoconic patient. You want to look for strange bumps in the sclera as well, and you'll see right here at sort of 3 o'clock, you've got that bump, yeah, right there. You got a little strange bump on these scleras. Go ahead, next. And in this particular patient, that was that superior area. And then you have, of course, things like pinguiculas and odd-shaped eyeballs that you have to deal with as well. And so you want to be able to bump or be able to take an area of a lens and be able to bring that area up, or negative bump, bring that area down. Sometimes when you do scleral profiling, you end up with artifact, right? Whether it's artifact at the edge of the optics or of the scan, whether it's a piece of conjunctiva that's folded over, a little something that's floating in the eye, just a random dry spot on the eye, you end up with artifacts. So you want to be able to smooth or remove those artifacts from the sclera, the profilometry images. Next. Okay, and then of course you want to be able to control your center thickness and materials, your optic zone sizes, your powers, and all of that as well. Okay, another thing that we are talking more about recently is being able to fenestrate your scleral contact lens. So fenestrations can have several advantages. One is I personally think, and I'm studying this and looking into this more, that we end up with this suction effect that happens under these lenses, and I think suction actually causes many of the problems that we see. It causes the lens to suck back or pull back to the cornea, causes hyperemia at the limbus. I think it causes some redness of the eyes. It certainly can cause some compression of blood vessels. I think it actually has a negative effect to the endothelium as well. This is just my point of view. So I think fenestrations may be something that as we learn to control them and learn where to put them. If you want to release suction, you can put channels or fenestrations out into the peripheral haptics of your lens. If you need to oxygenate a cornea though, you'll want a bubble that that's a transient bubble that draws in and out from underneath the lens. And this certainly can be a lecture in and of itself, because where you want the bubble and how you want it to leave in and out from underneath that lens, how you want to reduce suction under the lens, that's going to depend on where the fenestrations are and the size of the fenestration hole. So we'll leave that for a separate topic, but definitely let's go to the next slide there, Clark.
This one video slide or no?
Yeah, I think we're going to run out of time. I really would like, and here is his final lens there, and he was quite happy with his lenses. But Clark, I think we're going to run out of time, so let's just skip to the HOA section, because I think you want to touch a little bit on some of the higher order optics for keratoconic patients.
Sure. Yeah, so here's a case that I worked on with my resident, Dr. Kevin Fan. So it's actually his patient. I want to give him a shout out. So a patient who was in prior years were already fit in a free-form lens in one eye, in the left eye, as well as a scleral lens, but standard in the bitoric standard scleral lens in the right eye. Patient came in, no over refraction, pinhole doesn't improve. 2030, 2040, remember the left eye is post-corneal transplant, and much more comfortable than the corneal GP that this patient was wearing 3-4 years ago. Last year was refit into these two lens setup that I described. However, the patient says, I know I still get a lot of ghosting shadowing. Is that really normal? Is that sort of the best that I could expect? But the patient only notices on the right eye. Again, typically the better seeing eye is the eye that most of your keratoconus patient kind of pay more attention to, and that kind of the better seeing eye governs their overall binocular vision, if you would, even though one eye is usually more suppressed. And so, we thought, okay, well, then he thought, why don't we try to see if we could measure the amount of aberrometry, the amount of aberration that is residual with the lens on. And this is a demonstration, this is not a patient. And so we use the instrument and the lens on, cover one eye to reduce the possibility of accommodation induced myopia. And then this is then use that to create a lens with the engineers at the lab. And you could see that the amount of coma that was present in the right eye through the standard bitoric haptic scleral lens, we were able to redistribute with the first HOA lens to be much more even, right? I mean, I don't even think we have to look at the magnitude. You could see the distribution and say, oh, okay, that vertical coma is largely reduced. So that explains the going from 2030 to 2025 plus. But for the patient, she doesn't care that she picked up a line and a half. She cared that she didn't see any more ghosting or shadowing when both eyes are working together, or if she covers her left eye and viewing just out of the right eye. And you could see in not just the visual simulation of the E, you could see that E is much more tangible or much more visible. You could also see the majority of the higher order aberrations, especially at the beginning, that vertical coma throughout the roof, really to typically 0.3, 0.25 is noticeable. Anything above 0.4, 0.5 is really rather significant. This patient vertical coma Z7 has 1.8 micron. So that is so adding up to the total RMS of 2.01, dropping about 50-60%, like you heard other speakers have presented, to about 0.89. And I think I want to point out that it's very easy to look at that E and say, that's still not a good E. That still looks like you should see a lot of shadow and ghosting. Is there not anything else that you could do? And I would say if the patient would have complained to say, it's much better, but I still see a little bit of that ghosting halo, I then probably would try to see if we could more aggressively hit the probably just depending on the direction and the symptom the patient described. I think I may recommend seeing if we could maybe correct a little further vertical coma if needed. But because patient's happy, I really wouldn't recommend doing it again. But I do want to point out that is the reason why you're seeing still slight aberration that is more than ideal when you look at that point spread function or the visual stimulation. And this case is really interesting. Can I have you comment on this to kind of close out that case of seeing which lens people will pick?
Sure. So this is a case actually that's near and dear to my heart. This is my son who has keratoconus as well. And one of the things I want to point out here is his bare eye here on the left. You can see there's a lot of coma there. There's a lot of trefoil, and it created this visual E simulated below that. When I put a standard scleral lens on the eye, so this is a lower order aberration lens, right? A sphere cell lens. This patient, my son, he actually was more complaining of some of these HOAs. And what I want to point out here is how much blurrier that E was, right? It really messed up those HOAs. It put his blur in a place that he was not used to it. So what I want to point out here, and this is really important, like really need to listen to this part here, is do you see how that lower left, right about 7 o'clock there on the bare eye, we see a big blue patch, right? So in that case, we have some negative coma going on here. But when you put a scleral lens on the eye, that same area, that same place becomes a red patch. That means we turned it into positive coma. What does that mean? It means that we took flare that was going in one direction and we reversed it to make it go into the opposite direction. And so he's now seeing, and this happens in every single keratoconic patient, every single one. By putting a scleral lens, by putting hard lens optics on, we reverse those aberrations. And some people are going to be way more symptomatic of it than others. And it's all going to come down to their pupil size. Okay, that's very important. So sometimes we don't actually make their aberrations better. We make their overall clarity better, but we do really weird things to their aberrations. Now, this is his eye here. So we went from 1.43 microns of aberrations to 0.15 microns of aberrations when we corrected his higher order aberrations in a scleral contact lens as well. The interesting thing is, though, he didn't actually appreciate it. He actually, even though it cleared up his vision, okay, he didn't actually appreciate that it was all that much better. And he actually went back to his soft contact lens, which gave him about the clarity that he had in those aberrations with that bare eye, because he really just didn't feel that resolving those aberrations was all that much of an improvement. So I think it really goes to show a couple of things, Clark, and I know we're ending here, but you can maybe touch on this one last time, is when it comes to choosing your patients that you want to correct for higher order aberrations, you have to really make sure that higher order aberrations are their complaint, right? And that improving it, you may have better options just controlling their pupil size than putting them into an HOA lens, so that you can use your time appropriately. The other thing is there is such a thing as, I think, neuroadaptation with these lenses as well. And sometimes you put an HOA lens on a patient's eye and they're going to be like, meh. Yeah, it's fine. They don't have that wow factor that you really want them to tell you. But you have a story about that, Clark.
And sometimes worse, Christine, would you say sometimes
it's worse.
Yeah. So I think a good thing for me is when I agree with your point, when I put on a standard lens and we flip the direction of their aberration, such as from negative in this case to positive with a standard scleral. There are patients who would tell me, oh, well, it was two images below to the right, now it's up to the left. And I actually think that's better for me. I've had patients who say, I think that's less noticeable for me. And so if that were the case, I would actually say, okay, well, then let's try it out. We may not have to go to the high order aberration correcting, because that's a lot of chair time, a lot of work, a lot of adaptation on your part. You have to work really hard at it. Whereas this is likely, this raw data that we're gathering right now with my, with the lower order aberration that I've just shown you on a flipper or trial frame, that is probably a very good starting point. If patients say, oh, it flipped, and I think I really are having a lot of astenopia type of symptom that they're telling you, and that's what I think you're saying about listen to your patients, then I think that's not a patient I want to continue in a standard GP or standard scleral unless we want to commit to the process of building HOA scleral lens.
It is a process, right?
Yeah.
It is, and you have to, if you want to take this on, you have to be committed to the process. How many extra visits it's going to take, how many extra lenses it's going to take, and how comfortable you are billing your patient for not only your time, but how much time and effort is it going to take on your patient's part as well. They have to be well prepared for that.
Right. And just to close the case that you were alluding to, so I had a patient who came to me from having after cross-linked and then stabilized keratoconus impacts to see if they could improve, because she was rather GP intolerant in terms of she's willing to wear it as much as she can, but she's not as comfortable and always feels like something's in the eye, even though she's able to tolerate it for most part of the day. So they thought, well, why not do this is many years ago. So for her, where she did her impacts, and all of a sudden her vision, according to her, I don't usually see cases like this. I usually think vision is about the same or slightly better. I've never really seen it worse, but for her, she apparently felt like her corrective vision with the GP after Intacs was worse. And so they removed the Intacs and then refit her in a corneal GP, still worse than prior to Intacs procedure. And they try a scleral lens, even worse. She's one of those patients that Christine talked about where they notice the difference in that optical distance. And she's even worse in the scleral. So she didn't know what to do. She came to see me. We eventually decided after seeing her for a while, do you want to try HOA scleral lens? Let's give it a try. I went through 3-4 lenses. Every lens is worse than her corneal GP, down to the point where she was 2400. But the very last lens, I looked at that Zernicke display. I worked really hard with the engineers at the OVIDs in terms of thinking, okay, because sometimes when you hit you correct some of the higher order aberration in the higher frequency, like your Z12, Z13 or above, it will spill over and it will affect your lower order aberration and some of the, like your vertical coma in the lower order, high order aberration. So it is possible that first one or first two, maybe they, the redistribution of the HOA makes them not appreciate what they've neuroadapted to prior. So I always tell them that first lens, at least give me a chance. That first lens, go home and try it. And let's make sure you can wear the lens before we decide how to redistribute the correction of the HOA, knowing we're not going to go down to 0, because 0 is not good for these patients either. They've neuroadapted to some blur. They don't really want to let that go. So for her, the very last lens, she put it on up on this dispensing. She said, oh, it's still very blurry. I really can't tell. It's still 2400. Well, 3 weeks later, when she came back, I didn't do anything. She was 20/20. She cried in my chair because she didn't believe that going home to try wearing the lens again after 3 or 4, this is her 3rd or 4th, that it would make a difference. And it did this time. So sometimes you just have to ask your patient to really commit with you.
Yeah, I think that's the hardest thing, Clark, is doing these HOA lenses is it's disheartening to you as a doctor as you go through it and the patient doesn't have that wow factor and they're disheartened and they've spent money and you have to tell them to go home and wear it and they don't want to wear it. But I will tell you, universally, the patients come back. Even I've had patients, a year, 2 years come back. And if we put their old lenses on, they'll say, I don't know how I was able to walk around without them. But it's a long-term goal. You really have to set your patients up for that and really have that conversation with them ahead of time. You're probably not going to notice the difference. You're probably not going to think it's worth the money. You have to believe in me. You have to put your trust in me that I'm going to help you get through this. And so, yeah.
Yeah. So with that, that's the end of our lecture. We'll see if Dr. Ariel's around.
Yeah. Hey.
Hey, she's back. Yay.
Thank you guys. That was such great information.